re-expanded. So these are just additional things you kind of need to think about beyond your everyday EMS practice. Inhalation injuries, we talked about the oxygen deficient environments, something to think about. Providing oxygen to a patient in the rubble pile is logistically difficult and relatively hazardous, just from an ignition standpoint. So our general rule of thumb is we don't provide supplemental oxygen to the patient unless we're pretty sure they need it for whatever reason, an airway problem or something like that. But sort of the reflex about let's just slap some oxygen on the patient like we very often do in civilian EMS is not a practical move. You can't take a big cylinder in with you. That little cylinder is going to run out before you've gotten the patient out. Do you swap out cylinders? Is the tubing going to get snagged on stuff while you're moving them? It's just not worth it. So in general, we try to avoid the oxygen unless we're convinced the patient really needs it. I mentioned before just that patient that they could talk to but couldn't yet see, but it's amazing how much you can learn about a patient with very limited information. One of the fun drills that we do that you guys can do easily on your own without any real particular training is the assessment of the sensory deprived exam. So take this room, tip over a few tables, put a patient on the other side of the table, turn off the lights and tell the paramedic, go see what you can learn about the patient. You don't need a lot of fancy equipment to do it. It takes half an hour to do. It's kind of a fun drill. If you're talking to the patient and the patient is talking back and making sense, your ABC exam is done. Their airway's intact, they're breathing, and they're circulating enough that they're perfusing their brain. I don't care what their blood pressure is, the details are not important. If you're carrying on a conversation with a patient, their ABCs are intact. And it's not like, that's not a big revelation, but that may be as far as you can go with this exam. If you've got airway issues, if the patient can cough the stuff out, that's going to work better than suction, and getting a suction device in, and doing that in the rubble, not a very useful option. If there's a lot of dust involved, yeah, humidified air, humidified oxygen, wonderful, very helpful. But can you do that? Is it logistically feasible to do it? So it just may not be worth the effort. Hypovolemia. You guys know what to do for a hypovolemic patient, but remember that if you're, let's say you're part of the local team here and you get deployed over to Christchurch. I don't know how long it took them to get there. I mean, we may hear that later on. It's a couple of days. You're not going to be getting there, 3 hours into this event. You're talking 24, maybe 36 hours into the event before you're actually in contact with patients. So that's a patient who may have been bleeding, is definitely losing fluids through the usual processes, urinary losses and breathing losses. They probably haven't had anything to eat or drink while they're in the rubble pile. They're going to be dehydrated by the time you get there. A lot of other ways that they could be losing fluids we'll talk more about this afternoon. So that's something you're more likely to see than typical. So the usual assessment processes, you guys know how to do this stuff, but urine output. All right, do you put a Foley catheter in somebody in the rubble? Once in a while, you may actually have to, depending on what the circumstances are, and generally try to avoid that as well. If you can get an IV in them, that's very helpful. I don't really want these people eating and drinking if I can avoid it, because I don't know what their future course is going to look like. So IV hydration is preferable if you can do it. And another fun drill you can do, again, is tip that table over, put one of your IV dummies on the other side, turn the lights out, don't give anybody a flashlight, and see who can start an IV kind of in the almost dark, limited circumstances. Antiseptic technique is important. God knows what these people have been laying in for the last 12 hours, 24 hours, 36 hours, however long it is. They're probably hypothermic, not likely to be hyperthermic, even if the weather outside is fairly warm. In my circumstances in Connecticut, if I have one of these events in the middle of winter, where it's minus 10 centigrade on a fairly regular basis, hypothermia is going to be a big issue. But again, do you have the resources where you can warm up the IV fluids first? No, probably not. So you just got to kind of do the best you can. Blast injuries, I think it took somebody who really had way too much time on their hands to come up with a classification system for the different types of, do I really care in the emergency department whether the patient suffered a secondary or tertiary blast injury? No, I'm going to diagnose the injuries and move on. But there is a classification system if you're interested. Here it is. But the basic principle of blast injury, if you are in a confined space, and that could even be a large room or larger than this, the effects of an explosion are substantially greater than if you're outdoors. So just knowing whether the person you're treating was in the area or outdoors makes a huge difference in terms of what their injuries are likely to be. And again, some of these injuries here, if you're going to be taking care of this patient in the rubble for a few hours before you get them out, is things you need to think about. Orthopedic injuries, very common. We carry lots of IV antibiotics. If I can get some IV antibiotics into somebody who's already 24 to 36 hours into their open fracture of their humerus or whatever, before I get them out to a hospital 6-8 hours later, that may be beneficial. So we're actually pretty liberal with the IV antibiotics. Same with the pain medication. These are patients who are not happy. They've been in these circumstances for way too long. So I'm convinced that at least back home, I think we underdose our pain medications in general. So I teach our guys to be pretty liberal with the pain medications. And again, the immobilization process, if I think there's a good chance of a spine injury, yes, of course I'm going to immobilize it. But I'm not going to reflexively immobilize the neck just because I think I should. We try to minimize that just to make life easier. So pain medication, sedation in addition to analgesia may be helpful. We've got a fair amount of benzos if we need them. And I'm going to stop there. I'll see if anybody has any questions at this point. This is just a picture from that drill I was telling you about. We had some of the victims kind of up under here, and these are the rescue guys playing with their new toys, which is basically what they like to do. If anybody has any questions about anything I've talked about so far, I'll be happy to cover them. And then this afternoon, I think it's the last session if I remember right, we'll go into a little more depth on crush injury, crush syndrome, compartment syndrome, some of the more the sort of clinical details. So anybody have any questions or anybody want to add anything to what I've said or argue with me or refute something I said, that's totally fine too. Go ahead.
Look, that was a great talk. Thanks very much for that, Dave. One of the things that I guess a lot of us don't think about is that dust inhalation sort of syndrome. So in like sort of 5 words or less, what are the hallmarks of
So the basic issue is that they're inhaling dust and they can't, there's no way to escape the environment. So they're just inhaling dust and the trachea and lower airways are just getting lined with dust. There's the sad part is, there's not really a whole lot you can do about it, frankly. You can swab out their mouth, wet gauze, whatever. And you can give them supplemental oxygen to try to improve their oxygenation. And that's really about it. If you're going to get them to a hospital where they can get bronchoscopy and kind of literally flush some of that stuff out, that may be helpful. So it's really more sort of an awareness issue. Those are the patients who may need oxygen because you've impaired the alveolar gas exchange with physical mechanical dust. So those patients may actually need the oxygen. Those are the ones that may truly benefit. Beyond that, there's not a whole lot you can do in the field aside from give them a mask, prevent it from getting any worse. And be aware of it. There's no real magic bullet for it. And there's very little research on it. If you do a Medline search for it, you'll find some papers describing those patients from Kobe, but they're just descriptive. There's no papers describing, we tried this or that treatment, unlike what we'll talk about this afternoon, where there's a moderate amount of literature, not a ton, on different options for crush syndrome. Do IV fluids really help? Should I give bicarbonate or is that a waste of time? How often do you really need dialysis for these patients? There's actually pretty good literature on all that. For dust airway, there's really not a whole lot. Maybe it'd be a cool study, in the animal lab. I suppose you could kind of play around with it a little bit, but I'm not sure what the endpoint would be. So I don't know if I answered your question, but that's about what we know about it. It's a problem, and there's not a whole lot you can do about it once it's already occurred. And again, the timing, Kobe earthquake, the Japanese folks got there relatively quickly, but a bunch of U.S. teams went over. Well, you're talking about 2.5 days to get the team deployed, fly them to the West Coast, get them across the ocean, find somewhere for them to set up, get them going and all. We're talking 48, 72 hours in. And at that point, you're dead from the dust airway impaction or you're not, and there's not a whole lot of that you're going to do with it at that point. So, go ahead.
It's great hearing what you do in the US. And I was just wondering, when we went to Christchurch, we had a 73 heavy USAR task force. We had some structural engineers and a couple of police. You've got 62 on your heavy USAR task force. Do you include police or structural engineers?
Yes, we have 2 structural engineers. Actually, I think we have 1 honest-to-God structural engineer who's got no emergency, background. He's just an engineer. I can't remember if we have 1 or 2 on the Pennsylvania teams. I haven't been with them for a while, to be honest with you. But we do have structural engineers, and their basic function is to assess the stability of the structure. So in this particular drill that we had here, they're not rescue guys, they're not firefighters. They're just, they don't quite come to the drill wearing a shirt and tie, but I think they would if you let them. But their job is, okay, I've got some access to this part of the building. I need the engineer to take a look. Is it safe for my guys to be operating in here? What kind of stabilization and shoring do we need to do? Wood beams and stuff to make it a safer environment before we move on. So it's purely a mechanical engineering kind of guy. Yeah, we have at least 1 of those, and maybe it's 2. I honestly don't remember. But that was that guy's function, is to assess the stability of the building. So depending on what the circumstances are, there may or there may not be work for that person to do. There is a fairly big science developing on the whole concept of where you're likely to find the patient. So if you've got a multi-story building and it pancakes, straight down, you're not going to find any victims. Where you're going to get the victims is where you get what we call a triangular type of collapse, where maybe this part of the floor, but then you've got a useful void over here, so anybody in there is probably alive. There's actually a fairly big science developing around assessing the buildings and trying to predict where the survivors are likely to be, so you can concentrate your efforts on that part of the building. I don't pretend any expertise on this at all, but the structural engineers, this is what they do. So they can provide you, particularly if it's, again, a discrete scene, one building like in Oklahoma City, they can assess the building post-explosion and say this part of the building is unlikely to be survivors there because this part of the building is not particularly safe because maybe you guys should start working over here while the construction guys start reassessing and shoring up parts of the building over here. Typically at one of these events, we carry some equipment for some stabilization and shoring, but we're not going to be carrying huge amounts of timber for shoring up walls and all. It's just not practical to carry that around. So if you look at all the pictures from Oklahoma City, for example, I keep coming back to that one because I know a fair amount about it. You'll see a lot of pictures with a lot of cranes in the front of the building, and those are obviously not cranes that the teams brought with them. They hired guys to come in with their cranes to do a lot of the physical removal and hired local construction companies to bring in all the supplies they need. We need a whole mess of 4x4s for shoring and stabilizing the building, etc. And that's where your structural engineers will come in to help you with those sorts of things about how to make that work. And then they'll work with the local construction guys and say, okay, we need to stabilize this part of the building. The engineer will provide the advice to the construction guys. And part two of your question was law enforcement. We do have a couple guys on our team that are police officers as well as fill in the blank. They might also be paramedics, firefighters, or whatever. And they'll help us make sure that the law enforcement pieces of this are taken care of. Mostly what it turns out to be is interfacing with the local law enforcement. I mean, they're not, like guarding the camp like MPs. I suppose you might need that at some point. But yeah, we do have some law enforcement guys. And interestingly, pretty much everybody on our team is cross-trained to do a couple different things. So we don't have, except for perhaps the structural engineer and the dog handlers. But many of the firefighters are also paramedics. All of the paramedics on my team are also firefighters. So when we're in with the rubble with the team, the rescue guys know that the medical guys are also firefighters and can help out with some of the rescue components. They know how to run the tools. They know the basics of structural rescue. And that makes it a little bit easier instead of saying, okay, all this guy can do is X. Well, this guy can actually do X, Y, Z, and probably A through L, and give them additional tasks to do. So we do, especially in our training, we do a lot of cross-training and getting familiar with what the other guys on the team can do so that you know their capabilities. I'm also a firefighter. I've worked in EMS for a while. The other docs, almost all the other docs on my team have some field and fire background as well. And that lets the paramedics and the rescue guys know we're not going to be getting in the way, we're not going to be a liability, we'll be able to help you with some of these circumstances. Does that answer your question? Okay. Any other questions? Anybody else want to throw in any comments about?
You mentioned using morphine for pain relief and benzos for sedation. So you guys using ketamine?
Yes, morphine, I don't have the cache list in my head. Actually, if you go to the US FEMA website, it's fema.gov, FEMA.gov. All of the equipment lists and everything are there, and it's all public domain stuff. The medication list is huge. It's several hundred medications. So several benzos, morphine, fentanyl, we got a whole bunch of options in there, yeah. Yep. And there's some variability in there as well. You're not, there's a minimum that you need to carry. If you want to throw some extra stuff in, you can. My state team in Connecticut, because we're not part of the federal network yet, that's kind of our long-term goal. We've kind of played around with that list a little bit and adjusted it to what we're comfortable with. But the list is huge, the list of medications. We don't carry blood, by the way, in case anybody is wondering. It's just not feasible logistically. So we don't carry blood. It's just not practical.